Forgive me if I seem a little smug today. I was talking to a student that I'd helped very modestly prepare for the STEP exam, and he wrote me back and said I passed. So I said, really proud of you. Congratulations. Know what a big feat that is. Tell me about the exam. He said, well, it was a really hard exam because it kind of felt like I was talking to you. And I said, well, what do you mean by that? And he said, it was actually as though I was talking to an advanced clinician who understood that I was just a medical student. I said, well, yeah, that sort of does sound like me, doesn't it? And he said, it was extremely helpful. He said, a lot of the things that I probably wouldn't have studied were related to vocabulary and how to think about things. So I was feeling pretty good. How could I not? And then I said, well, if you could go back to the beginning 2 years ago, what would you do differently knowing this is your exam? And he said, well, I would just start with pathophys and end with pathophys and everything would be pathophys. I went, well, sounds good to me. Today, I want to talk about something near and dear to my heart. I want to talk about this idea that testing teaches pathophysiology. Every week, I do a video trying to help students understand how doctors think and how they use the basic sciences to underpin how they diagnose and treat patients. If that's the kind of doctor you want to become, be sure to subscribe. I'm Dr. Philip Tisdall. I practiced community hospital pathology for decades, and now I've been teaching over 12 years. Testing teaches pathophysiology. And what that means is when we walk through our pathophysiology, we walk through a sequence of events where some sort of injury starts to degrade the normal function. And that then has a cascading effect that ends up with your patient with a symptom, and you uncover it in the physical exam and testing. So if you understand why a test works, it means that you've gone to one of the central steps of the pathophysiology. Let me give you one of my favorite examples. It comes up all the time. Ischemia, really common, right? 630,000 deaths a year from heart disease. And you say, okay, someone comes to you with chest pain. How do you understand if they've formed a thrombus in their coronary artery and heart muscles dying? And of course, every student can tell you troponins. And you go, but why? Explain that to me how troponins work. And the answer is actually molecular cell death, because we're talking about the MPT-driven calcium in rush. Cells dissolve and the cell membrane dissolves and everything in the cytosol spills into the interstitium, at which point we usually have to stop and talk about what interstitium is. And then I say, okay, but you drew a blood sample. So how do we go from cell membranes dissolving to blood sample? And of course, everyone then just hasn't gone through the sequence of interstitium to lymphatics, lymphatics to thoracic duct. Thoracic duct is going to dump into my left subclavian, and there we have it in the blood. So I said, well, if that's true, how long does it take? And of course, the correct answer is, I don't know. How sensitive is your test? Because when we first started doing troponins, after the year 2000, and I'll remind you, I'm the class of 1976, the answer was 4 hours minimum. But then we went through, by the third generation, they were really sensitive tests, and 1 hour was enough. And that shouldn't surprise anyone that had this idea of cell membranes dissolving, interstitium, lymphatic pickup, traveling thoracic duct into the veins. You'd say, well, it must start trickling in sooner, not later. And so that really makes sense. And then you say, well, why troponins? And this is where students are really shocked, because back when I was training, 50 years ago, we used to use LDH. The trouble with LDH is it's an anaerobe enzyme and every cell has it. So it wasn't that LDH didn't work, it's that it was nonspecific. And a great breakthrough for my generation was CKMB, which was way better because now we're only talking muscles. Yeah, but we're talking all the striated muscles. So that's a problem with your skeleton. And then lo and behold, we had cardiac specific troponins and everything was fantastic. Until we got to really sensitive troponins, and then it turns out stress events in the heart can leak troponins. So what do you mean by infarct? Well, now all of a sudden we realize testing teaches pathophysiology. Cells aren't necessarily alive and dead. Cells go through decompensation and stress periods. Well, that's a deeper understanding of heart disease, isn't it? It's really useful when you think about how testing teaches pathophys. just to go through the history of congestive heart failure across testing. It's just a really fun thing to do, and it's really helpful. Supposing you went back and you were before the Civil War. So this is prior to 1860. The answer was patient would be short of breath, and there really wasn't a lot you could do except offer sympathy. But boy, by the time we get to the 1870s, now we've got stethoscopes, and now we've got the beginning idea that symptoms follow pathology. And now if you go back and read the literature following 1870, now all of a sudden you realize people talk about the shortness of breath, and they break it into two groups because they're seeing in autopsies the pathology that correlates with their patient's symptoms. And they're going to break it into left-sided, in which they can hear crackles. I don't think they had good enough stethoscopes for an S3 then. Or they had JVD and edema, which was right-sided. So that's why we sort of see this legacy universal term of calling it congestive heart failure. I have trouble correcting myself. I should just call it heart failure, but it's an old legacy term that comes from when you only had the physical exam. Okay, what then was the first test that was objective? And the answer is, I'm not making this up, hemosiderin-laden macrophages. They had pretty good dyes back then, and you could do a Prussian blue stain, and you could show that macrophages the patient would cough up in their sputum contained iron from the hemosiderin. Well, you only get hemosiderin because you've ingested and broken down a red blood cell, which is a marker of congestion. And they knew there was congestion. They talked about the tawny or brown lungs of the long-standing congestive failures. So that became the test that they had, I'm not making this up, till about 1940. So for all those decades through that period, your objective test after crackles and JVD was the hemosiderin-laden macrophages. And you see that. We use it all the time because it's a fun way to test congestion. Then, starting in academic centers, maybe the 30s and 40s, we start to see good chest x-rays, but they aren't going to really have widespread use till after World War II. So starting in the 1950s, we see this kind of dropping the hemosiderin-laden macrophage, and we go to the chest x-ray. And the chest x-ray is going to do two things that matter, right? It's going to show cardiomegaly, which is evidence of remodeling, and it's going to show the flaring in the hilar regions of edema. That was so much better than the hemosiderin-laden macrophages. It kind of vanishes, and now everything's chest x-ray. About this time, we really start seeing the EKG come in. So by the time I'm in med school in the 1970s, we really are definitely living on the chest x-ray and the EKG. And EKG is a really powerful test, even in ischemia, right? Because we get the ST changes. Well, about the time I'm in med school, so we're talking, probably 1965 through 1980, we get catheterization. So they would literally thread the wire up the artery, and that allowed them to inject dye to see things and to measure pressures. So this was really revolutionary after the chest x-ray because now all of a sudden you can measure cardiac output, you can measure pressures across valves, and you can flush dye and see the shapes of things. So testing teaches pathophys, that was just way better, really invasive. So the big revolution's going to come about the time I get out into practice, 1980s, 90s. Everything is echo. Oh my God, echo was so great because echo is going to give us two things. It's going to give us structure, and it's going to give us an ejection fraction. So now all of a sudden, everything's going to be, how is the pump working? Because you could do an ejection fraction, more than 50%, less than 50%. Really wonderful. But understand, we're still kind of in systole, aren't we? About 1990, that's going to be replaced by Doppler echo. What that's allow us to do is it's going to give us pressure flow dynamics, way better when you're evaluating valves and function better, but it's also going to give us diastolic pressures. And now for the first time, we're talking about two different types of failure. And honestly, it's very confusing. I have to go back and rethink it through because it was taught so confusingly to me. We talked about forward failure and backward failure. We talked about congestive failure and flow failures. But nowadays, of course, we talk about it as reduced ejection fraction and preserved ejection fraction. And all of a sudden, that discussion has become enormously important because we have our SGL2 inhibitors that change with the preserved ejection fraction. So what we always knew to be increasingly true now actually is treatable. Then came the revolution. In the year 2000, we get BNP. And now all of a sudden we have this wonderful test that you can order very simply from the lab. And they're in failure or they're not. But again, now notice what we're doing. We're not measuring flow and function and ejection fractions. We're measuring myocyte stress. So all of a sudden you can see we're really evolving in how we think about the pathology of heart failure. We've gone from congestion to the pump, and now we're talking about stress. And so BNP has been really profoundly changing before and after for everyone that didn't live before BNP. Trust me, it's a really good test. So what's happened after that? Well, maybe starting 10, 15 years ago, we started talking about strain imaging. We talked about how much strain is the heart going under. Well, BNP is a pretty good measure of that, but we're also developing it from imaging techniques. And then the last great revolution that we're just seeing now is cardiac MRI, because now all of a sudden we can look into the heart. And now we're not just talking about function, we're talking about fibrosis, we're talking about infiltrates, we're picking up transthyretin amyloid. It's a whole new world in which we're talking about the actual contents of the heart wall. Every step of the way, the disease has been the same. But as we have new tests, it's really supporting clinical diagnosis, but it also changes how we think about the pathology. We've sort of gone from the very early congestion era to the X-ray era to the pump factor, and now we're into the wall stress strain factor. I'm sure there's more to come. So that's a really good discussion of testing teaches pathophys. We've used the example of necrosis, but there are lots. I mean, seriously, I was thinking maybe we should do a whole course on this. I just want to end with this fundamental idea in pathology. It's the difference between structural abnormality and functional abnormality. And I really lived this. I did nuclear studies for, I don't know, 20 or 30 years. And so we did nuclear cardiac stress tests. And when you'd inject the tracer would only go to the parts of the heart that were perfused. So when the patient was exercising, and you would inject the tracer, if you had an obstruction, that part of the heart would not light up. It was a functional test. And we had to compare those to the angiograms, which are lining the blood vessel and saying, what percent stenosis do you have? 70% being the usual breakoff for significant and insignificant. And I would bet 10 or 20% of the time they were discrepant. We would see an area that didn't have perfusion on the nuclear stress test, but the angiogram didn't show anything. Or they would have, this is an 80% occlusion, and we would say, no, it's perfusing. And we got into big arguments about which was truth. And the answer is, neither's truth, it's just testing. Another really famous example is looking at renal artery disease. Because if you do an angiogram, again, the same rule of 70% works. But supposing you have 60%, but it goes a long way, how do you judge if that's significant? And when they started doing this evaluation after probably in the 60s, 70s with the angiogram phase, one group at Mayo realized you could do a functional test to decide if the structural 60 to 70% was significant. And you know what they did? They did renal vein renins. Because obviously renin is a function of the JGA, and it will go up in underperfusion. And so this whole gray zone group could be divided into surgical, non-surgical by taking the structural test of occlusion, but then interpreting it on the functional test of vein renins. And all of a sudden you realize this is a really great teaching moment, and I can take you back to the JGA and we can go through how the macula densa works. There are obviously other really good examples. Take a look at lung. You know, when we're doing lung now, if you'd gone back even 10 or 20 years, I would have said to you, let's do pulmonary function testing. And in COPD, that's going to be our FEV1, isn't it? CTs are so good now that you can actually measure the tissue loss and emphysema from the CT. So what's going to be better, what your PFTs are showing or what your CT is showing? And the answer is, well, you can't reconcile. It's a structure-function trade-off. So you can see as we're going through this discussion, the idea that testing teaches pathophys means that you have to have this really deep understanding of pathophys, both in a structural and in a functional way. And you can see as we dance through the history of congestive heart failure, how every time we go from insensitive, nonspecific tests to better and better objective measures. And as we do so, the tests not only teach us diagnosis, they actually change how we do our pathophysiology. So I think that we really need to start a course in which I name all the tests and you tell me why they are really good measures of pathophysiology, because it means you have to know the pathophysiology. If you want to go deeper into this way of thinking, I wrote down all my ideas into a 2-volume textbook. To purchase the textbook, click the link in the description. And if you want to experience this live, with case studies and multiple choice questions and discussions like using lab testing, you can join us every week at Medical School Companion. For more information, visit drphiliptisdall.com. We'll see you next time.